Welcome to Season 5 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former health commissioner here in Baltimore, Maryland. Our goal with this podcast is to bring scientific evidence and experience to shed light on critical health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith-Rogers, producer of Public Health on Call. Today, Stephanie Desmond talks to Amy Killalea, a policy expert on HIV and public health financing, about the Biden administration's decision to budget billions to end the nation's HIV epidemic, including nearly $10 billion to broaden access to a medication that is 99% effective at preventing HIV, but only if people can access it. Let's listen. Amy Killalea, thanks so much for joining me.
It's great to be here.
So today I want to talk to you about the Biden administration has put combating the HIV epidemic in the United States into its next budget in a big way. So talk to me about what does this mean?
Yeah, it was an exciting week when we saw the president's budget come out, and it means a few things. So the HIV epidemic has been funded for many years in the U.S. So in some ways, we always see something in the president's budget. And we saw increases, which we expect to see from this administration. This administration has been very supportive of HIV efforts. And so you saw, increases in both the regular funding that goes to HIV prevention and care and treatment programs in this country, and as well as a significant investment in the Ending the HIV Epidemic Initiative, which was an initiative launched under the former administration, but continued under this administration. Now, the thing that was fairly new and I think particularly exciting was language in the president's budget announcing a commitment to a national PrEP program. So PrEP is pre-exposure prophylaxis. It is medication that folks who do not have HIV can take to prevent getting HIV. It is incredibly effective. It is incredibly underused in the U.S. So we saw in the president's budget a commitment and a fairly significant commitment of $9.8 billion over 10 years of mandatory funding for a national PrEP program. And that would focus on folks who are or underinsured. And then there were also components in the president's budget that requires Medicaid to do better when it comes to PrEP access. So that part was new, was big, and I think offers a lot of challenges, but a lot of opportunity for really ending the HIV epidemic in this country.
So talk to me about why PrEP is so important and why it's sort of been slow to roll out here in the United States.
Well, so I'll start with the first question. PrEP is an incredibly effective prevention intervention. And, when I say that, we've got clinical evidence that indicates the oral-based medications are up to 99% effective in preventing acquisition of HIV for people who take it regularly. We don't have that kind of, highly effective, incredibly safe intervention. So you have, just by the science of it is quite remarkable. Now, the first PrEP medication, a once daily oral medication, was approved by the Food and Drug Administration in this country a decade ago. And despite all of the promise and all of the hype a decade ago, we are now at only hovering at about a quarter of the 1.1 million people in the U.S. who could benefit from PrEP. Only a quarter of that number are actually taking PrEP. And if you even break that down by demographics, you see that Black and Latino, Latinx populations are even less likely to access PrEP. And yet those populations are more likely to acquire HIV. So there is a disconnect. We've got this incredible intervention. We know that it works. We know it's safe, and people aren't taking it.
Why not?
That is a hard question. Many, many reasons. I think there is stigma associated with HIV and with PrEP. There are providers who either don't know about PrEP and so aren't offering it as an option for their patients, or don't believe in PrEP. And there's stigma in the provider world, as we know, just as there is in the general public. I'm a systems person. I'm a policy person. So I go to, what systems are at play that either facilitate or put in place barriers to access. And I think we have an incredibly broken public health and healthcare access system for PrEP in this country. I think one of the reasons for that is that the price of the drug when it was first introduced 10 years ago was very, very high. We had only brand name drugs available up until only about a year and a half ago. And the cost of that drug was high. And we built up a complex and fragmented system around this high cost drug. And so now we are left with a very confusing system that you can get medication access. We rely heavily on manufacturer assistance programs, on donation programs. We don't have an easy path for all of the other services you need when you're on PrEP. So if you're on PrEP, it's not just a pill. You also need regular access to lab services to make sure you're doing okay. And then you also need ancillary services, just like you need with taking other pills, to make sure you're getting other services that you need and that you can be adherent. PrEP only works if you're taking it regularly. So we have an incredibly fragmented system, I think, for many, many reasons. And I think one of the big ones is that we have not figured out how to ensure effective, efficient access to services at a fair public health price.
Mm-hmm. So how can we fix that in your view? I guess this money will go a long way.
money always goes a long way, but I would say, it's not just money. I mean, you could just throw piles of money into a money hole, but if you're not using it efficiently, that's all you're doing. You're just wasting an opportunity. And so, that's sort of the excitement, I think, and the opportunity about this announced national PrEP program. Now, the president's budget is but a few lines. And so we see in it what we want and hope and aspire it to be. But I see it in an opportunity for a functioning and functional public health response to PrEP. We have not been able to really mobilize a public health response to PrEP because public health can't afford to do it. Public health cannot afford to have public health a giant community of public health providers giving PrEP to everybody who needs it, because we don't have those kinds of resources to afford a pill that is so expensive or an intervention that's so expensive. So, what folks at Hopkins and other colleagues, including myself, have proposed is a program that would secure federally negotiated fair public health prices for PrEP medications. And that includes, the generic version that's available now, and there are newer versions of PrEP. Just in December, the most recent long-acting version of PrEP was approved at a very high list price. So step one is to ensure that the federal government can negotiate for fair prices for those drugs, fair public health prices for those drugs, and fair public health prices for the labs that folks need. And this is particularly important for people who are underinsured or uninsured. There, we don't have a safety net to catch those people. We have manufacturer assistance programs and donation programs, and that is not a stand-in for a public health system. That is a patchy patchwork. So we've got, a negotiating mechanism for the federal government to secure those fair public health prices. And then I think what is really important is that it's not just securing those fair public health prices, for that as an end goal. You secure fair public health prices and you open up funding that can be deployed in a bunch of different new and innovative ways. So for instance, we have a fairly limited network of providers who are able to provide PrEP. Some of that is from the education issues that I talked about a minute ago. And some of that is because we have a really complex financing system where if you are a community provider in a rural area, you are not big enough to navigate the financing complexities of the PrEP system. So our national PrEP program would really take that, financing piece away and off of the charge of community-based organizations and really mobilize those community-based organizations and providers to be that first point of contact for PrEP. In many cases, mobilizing and building off of the momentum that we saw in COVID for telehealth. So pairing up, non-traditional community-based providers with clinical prescribers, because in most states you do need a prescriber to get PrEP to somebody. But telehealth is a great and underutilized way to ensure that you are actually going out to where people are, particularly people who are not walking into a primary care provider, who are not walking into a community health center or clinic, and really reaching them where they are. And I don't think you can do that part without addressing the financing, without making sure we are efficiently using resources.
And I guess an important part of whatever ends up coming together would be educating more physicians about the role they can play.
I think that's absolutely true. I think, we see that, and I hear it, from folks out in the field who are trying to get PrEP. My doctor never offered it to me, or I asked my doctor if I was a candidate and they said, no, I shouldn't worry about that. So we know that's a really big deal. I think, the U.S. Preventative Services Task Force giving PrEP a grade A rating. Now that rating is almost 3 years old now, helped to boost a little bit of the profile of PrEP, but we have a lot more work to do in really getting that word out. And I think that's an important component of any national PrEP program, to have that education component, to have that education of consumers and people, and education of providers, for sure.
I have heard this sort of called an inflection point in this whole HIV epidemic, which has been going on for decades now. Talk to me about that.
Yes. So I think one, we maybe have multiple inflection points, and this is but one for PrEP in particular. I mean, that we have an Ending the HIV Epidemic initiative in this country, and that's huge. And I want to, underscore that. That was a bit of a surprise from the last administration, but it is something that has continued, and I think is building momentum. And it gives the entire nation something to work toward that is ambitious, but I think ultimately achievable. I think with PrEP, 10 years ago, again, I remember the excitement around the studies that came out and the trial results and the FDA approval. And yet we were not able to really capitalize on that huge scientific investment and huge scientific advance. Mm-hmm. And so now 10 years in, I think it's almost like a do-over. We have now the long-acting cabotegravir version of PrEP that was just introduced. And you had this sort of similar excitement in the HIV community of where science is moving. Science is allowing us to, provide PrEP in all different formulations that can really be, tailored to what people need. And so let's do it right. So a national PrEP program and the attention that, the president has given to this concept in the budget, I think is an inflection point. It's a real opportunity to say, okay, we have another chance at this, and we will not do it right unless we sort of look at the entire system and look at where the systems does not work and start over and do a public health approach where we didn't 10 years ago. So I think it's right that it's an inflection point, and I think it's tied very much to the ambitious goals of the Ending the HIV Epidemic. The fact of the matter is we can't and we won't end the HIV epidemic here if we don't do better, much, much better in terms of PrEP uptake.
Mm-hmm. And I saw that, as you mentioned, the new injectable PrEP is really, really expensive. So it almost feels like we're coming back full circle if we're not careful.
I think that's absolutely right. And I think that's one of it's a fear, and it's also a mobilizing moment, because in some ways it sets us up to have this very urgent and timely conversation right now. We're dealing with it right now. And so, yes, when long-acting cabotegravir was announced, it's got a list price of $3,700 per dose, or, a little over $22,000 per year. That's list price, but that is incredibly expensive, and you cannot mobilize a public health response with a price like that. And I think the worry is that when we look at the history of the first brand name medication that was approved for oral-based PrEP, we saw the medication come out, FDA approved, high price, public health programs couldn't afford it. So you didn't have sort of rapid response and dissemination through your public health channels. We had to rely on manufacturer assistance programs. Those are hard to access. And then, we sort of missed an opportunity to have a real public health response. In the insurance market, we saw, as a direct response to the price, public and private insurers made it hard to get. They put prior authorization on it. And so the worry is that here we are, another blockbuster moment. And we are about, if we don't do something different, we are about to head down the same road. And I think, equity should really be at the center of this conversation. So, I mentioned at the beginning, PrEP uptake is low. It is particularly low for communities who need it most, and low for certain racial and ethnic groups. And if we don't reverse course on this system that we have right now, this very broken system, we're going to see with long-acting cabotegravir, the expense will make it particularly hard for communities who are already having a hard time accessing PrEP. And we will just see a continued worsening of disparities. So I think the price, it was disappointing to see. And I also think it has invigorated the HIV community and policymakers with a renewed sense of urgency around acting on the issue.
Amy Killalay, thanks so much for joining me.
Thank you for having me.
Public Health On Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Niall Owen McClusker, Matthew Martin, Spencer Greer, and Holly Cardinale, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media support from Grace Holz Fernandez. Thank you for listening.